So I hope you enjoyed your lunch. So I'm going to try and talk about personalized medicine for myeloma. It's taken us a while to get to grips with personalizing therapy, but I think it's probably the only way forward for us, and to kind of at least accept some of these concepts. So it's more of a concept talk I'm trying to give. Forgive me. So myeloma is a disease of plasma cells, and the plasma cells live in the bone marrow, and these are the plasma cells. They have a big cytoplasm that makes this M spike, and they're not evenly distributed through the bone marrow, and yet they're all related. And so those are important facts. They crowd out the bone marrow and secrete cytokines that suppresses your blood counts. So that's why people are tired when they present, because they're effectively anemic. It also punches holes in the bones, and those are the classic features of myeloma. And there you can see like a skull of somebody who's had myeloma, and you can see these discrete holes that the arrows point out, which are what the myeloma is actually doing to the bone. And not really holes, they're just regions where there's no calcium. In life, they'd be filled up with some rubbery plasma cell infiltrates. And so everybody needs to get inspiration from somewhere. And so I was out and about in Arkansas and came to Inspiration Point. So I thought I'd better do some thinking and to get some inspiration. And so if you want to know what causes myeloma, it's really quite simple. You want to know what makes a normal cell become abnormal and live, and then once it's started, what pushes the process forward. And so always reduce everything to the simplest possible idea you can come up with. Then you have some chance of making reasonable guesses about what really happens. And so we've always looked at the cells down the microscope, but hell, that's kind of old-fashioned. It's not really been helpful prognostically. Big cells do worse than little cells, and that's about as far as we've got. And so you have to get into the gene scene somehow or other. So we all start talking about genetics, genes, and then you wind up having to go back to school in some way or other. And so this is a DNA molecule and the DNA code. And this is a nice DNA molecule. It's nice and symmetrical. It looks good. But mutations happen. So be aware of it. We all know that. We all watch the X-Men, and Stanley's died, but the mutants live on. So this is all about mutated cells and mutated cancer cells where the genetic code is messed up. And that's about as much as you really need to know. And so we heard Rafa talk about the chromosomes. So DNA is packed into chromosomes, and you have, I can never get the number right, but 23 pairs, X and Y. And you should only have 2 pairs. And clearly here there's 3 chromosomes. So this is a bad cell. The chromosomes should all be the same colors and sizes, but you can see there are different colors on a chromosome. And those are the translocations, the rearrangements that Raphael talked about. And so the end result of all of this genetic damage is kind of weird things happen. The cells don't respond normally. And so the inspiration would be, when we've looked at all of these genetic features, that there are distinct subtypes of disease that respond differently to therapy, that have a different prognosis, different distribution of disease. So myeloma is not a single disease. I think that's completely clear. And so understanding those subtypes of disease is important because it can allow you to tell people about their prognosis, how it's going to behave, and how you should treat it. And so why, if we all clearly know that myeloma is not one disease, do we use the same treatment for everybody? And that's the bottom line. It's sort of foolish, and we have to get up to speed with this technology and really to sort out this puzzle and work out what's the best treatment for any individual patient. And so that is called personalized medicine. And although it sounds sort of far-fetched, actually doctors have been doing it for years. And so, we clearly recognize that there's one approach for younger, fit patients, and you push the therapeutic envelope in those patients, they survive better. Then there's the elderly fit. It's clearly a different group. There are different considerations. If you present you're fit at 68, how far do you want to tolerate the side effects of treatment? When you have comorbidities, you're forced to reduce the intensity of your treatment, and so you can choose for those patients. And then there's the very frail patients where you have to be very careful up front, and it's all about being gentle, allowing them some chance to recover and getting the best outcome that you can. So we do personalize the therapeutic decisions, but we haven't really bought in to risk stratification. So there are very few trials that have said, this is a very high-risk patient, we're going to do this, or this is an extremely low-risk patient, we'll not treat them so intensively. And yet, even clinically, you can recognize these very high-risk patients by extramedullary disease, plasma cell leukemia, some cytogenetic abnormalities. And so there really is a purpose in us trying to work on high-risk disease. And so there's this thing called systems biology, where really you take as much information as you can. You take the images, the genetics, the proteins, mash them all together and try and come out of that with a way of addressing this problem. So there's the puzzle in front of you. It's a jigsaw. They're not all of the same. And what you want to do is to split that jigsaw into its individual pieces. And so there are big projects out there have been done, like this Myeloma Genome Project, which has brought everything together. And what it shows you is that the genetics are super complicated, and you might say, too complicated. We can never get to grips with that. But actually, this driver idea versus a passenger idea is something that you should all be aware of, because while there's lots of passenger events that get carried along by the driver, there's only limited driver events. So there may only be 6 genetic lesions that determine how a patient's myeloma behaves. And so this is what we're trying to find: driver variants that push the disease forward or drive it along and carry these passengers with them. And so what we need is big data, more information, and we need a team of geeks who are prepared to sit there and struggle with this problem and come up with the drivers that we can use to segment the disease into its individual components. And as time has moved on, computer technology and analysis platforms have got better. And so you can use the computer to do the thinking for you. And using these integrative learning approaches, you can generate segments of myeloma. And so it's quite clear that there are only limited segments, probably 6, maybe more. But we're starting to get to what these segments are. And so it's like pulling out the patients from the overall group who you should treat differently. And so as diagnostics have got better, so we've seen cytogenetics, metaphases, iFISH, and now mutation panels, it's very easy to turn a genetic test around in a week and separate that puzzle into the 3 distinct groups. And that's all personalized medicine is about at this stage, is separating and segmenting the disease. And once you've generated segments, you can then put treatments to each of those segments. So we've heard these before, and I want to come back to them. So the 414 myeloma, 15% of all cases, it does well if you give it lots of proteasome inhibition. So you might want to focus carfilzomib onto the 414s. The 1114, a relatively good risk group, it responds to this drug called venetoclax, and really the other groups don't respond to venetoclax. So you suddenly have a tool where if you want to use venetoclax in the clinic, you need a diagnostic, and then you need to treat those patients with that kind of therapy. And there's venetoclax, and there's the responses. So you get 40% responses if you have the 1114. If you don't have the 1114, the response rates are kind of much less. We're going to utilize the immune system, and Leif did a good job of showing that. But we have all of those targets. Each of these numbers is a different target that's on the surface of the myeloma cell that you can target your antibodies against or your CAR-Ts. But life doesn't work like one size fits all. It works like some patients won't respond to CAR-Ts, and we won't understand why. And so we need technologies to look at the immune system. And this kind of technique called CytOff allows you to look at the whole immune system in one go. So you can expect us to try and personalize immunotherapy using kind of immune segmentation rather than molecular segmentation. Further, you all will, I know, hate having bone marrow tests. So you can combine blood biopsies with diagnostic panels, and then everybody in the country could have a rather cheap diagnostic test, get the result back in real time, and adjust their therapy in real time, and then use that panel to monitor disease over time. Further to that approach, imaging technology is becoming so powerful that you can extract what are called radiomic features from these plasmacytomas just from the imaging data, and some of those features correlate with prognosis. So as time moves on, our rather crude approaches will become increasingly sophisticated, and it'll make the information quicker, more robust, and patients' lives better. And so I'll finish there, and thank you.